Good morning. My name is Mary Leonard. I'm the chair of the Department of Pediatrics, the director of the Child Health Research Institute, and the physician-in-chief for the Children's Hospital. And I was really delighted that Dean Miner's opening remarks highlighted some of the innovative precision health and big data work going on in pediatrics, in endocrinology, oncology, and general pediatrics. My personal research program is on childhood bone development and lifelong implications for skeletal fragility, and I just learned that one of our speakers has a slide with a child on a skateboard. So I think we have some interests in common. So it's really my pleasure to introduce our speakers from the next session, which is dedicated to the National Library of Medicine, which I'm sure you know is the world's largest biomedical library and the producer of digital information services used by scientists, health professionals, and members of the public worldwide. Our first speaker, Dr. Patricia Brennan, is the director of the National Library of Medicine. She's also the NIH interim director for data science and oversees the Big Data to Knowledge initiative. She's a pioneer in the development of information systems for patients, and she specifically is eager to address some of the questions that have come up earlier today related to the patient's perspective. She developed a series of web-based interventions designed to reduce isolation and improve self-care among home care patients. She also directed Project Health Design, an initiative designed to stimulate the next generation of personal health records. Dr. Brennan is a past president of the American Medical Informatics Association. She was elected to the Institute of Medicine and is a fellow of the American Academy of Nursing, the American College of Medical Informatics, and the New York Academy of Medicine. Patricia actually retired with a goal of ending homelessness and then found herself in charge of the largest biomedical library in the world. She still has a goal to end homelessness, but now she will do it by using the power of the catalog to expand the definition of health beyond genes and phenotypes to home behaviors and environmental exposure, some things we've heard about in the last 2 days, and thus providing an enriched knowledge base for personal, public, and policy health choices. Please welcome Dr. Brennan. Her talk is titled Sustaining Data-Powered Health.
Thank you very much. Good morning. It's wonderful to be here. I bring you greetings from the National Library of Medicine and the National Institutes of Health, and I bring forgiveness to Ash, if he's still here. We've got that computer system fixed, and we don't have to worry about it being brought down by a big query any longer. I want you to look at my title for a minute. I'm talking today about data-powered health, which is a little bit different than precision health. We tend to have absconded with the term precision from the professional viewpoint of what health is. And I want to use my time today to address how the National Library of Medicine is building the infrastructure to sustain data-powered health, which means health from the perspective of professionals as well as health from the perspective of people. Data-powered health is experienced everywhere. It's experienced in the hospital. It's experienced north of the Arctic Circle. It's experienced in the hands of a little child. And it's experienced when a professional is present. So as we think about a future for data-powered health and how the National Library of Medicine fits in, it's worthwhile to spend just a couple of minutes to think about, to imagine what is data-powered health. You may have your own definitions throughout the meeting the last 2 days. I'm sure you've generated a number of definitions. Here are some of the characteristics that I found important. Data-powered health is, first of all, resting on data-driven discoveries that arise from and inform health care and health practices. Health care being what professionals do, health practices being what I do and you do every day. Now, we've heard several times that science proceeds at many scales. I'm going to ask you to think about the time scale, because often when we think about precision health, precision medicine, we're envisioning laboratory activities that somehow eventually get to the person. Those time scales of generating BAM files or creating a new model may take weeks or months, but at the point of the encounter with a person, they may be in a second. And so we need to think about the infrastructure that goes all the way from the origin of the data to the point of care and the point of living. Investigators must imagine the links human and non-human and contextual data for optimum discovery. That imagination of the investigator, I'm going to come back to a couple times, because frankly, that is something that the National Library of Medicine also is designed to stimulate. We want to think about data as not simply generated under the controlled circumstances and complemented with clinical care, but also with patient-generated data. Data that we can only know from the person where they live every day. And we want to think, and I would like each of you to live here today with a commitment that the data contributors must benefit at the point of capture as well as from the discoveries themselves. We cannot decide that patients are scribes that are simply going to collect data for our studies. We must find ways to engage them at the point of capture so the data that we get are good, and so their benefit of that data is not only what comes downstream in months or years, the altruistic contribution, but in the moment. Now, I ask you to think about that data-powered healthcare relies on a secure end-to-end pipeline. And that pipeline, the infrastructure, the information flows, the investigational pathways, the workflows, are often restricted to framing in a professional environment. But we must begin to think about how we're going to get that pipeline to East Palo Alto, how we're going to get a secure transmission line around the world, how we're going to integrate data through the point of capture, the point of an analytics, the point of use of recommendation to a clinician or a patient and back again. All the steps along that pipeline are important. Now, what can the National Library of Medicine do to sustain the ideas of data-powered health? We have two key activities that I'm going to be presenting to you today. Two key commitments. One is a platform for discovery, and the second is a pathway for engagement. The National Library of Medicine began in 1836. It was at one time a simple bookshelf in the office, in the tent of an army surgeon. Now, almost 200 years later, we're introducing our third century, and we are beginning to support data-powered health. Our future builds on our past. Those of you who are familiar with the National Library of Medicine probably know dbGaP, PubMed, PubMed Central, but you may not know all the things that we do. We index the literature. We've been doing this for over 150 years to make sure we can capture and note what is the corpus of medicine. Remember the big red books, the Index Medicus? That came from us. But in the 70s, we began to digitize that. In the 80s and 90s and early 2000s, networks became a pathway to both acquire information and disseminate it out. And now we're moving into a data-driven era. And the role of the National Library of Medicine in data-powered healthcare is fundamentally to provide a platform for discovery and a pathway for engagement. The National Library of Medicine as a platform for discovery brings you literature, brings you workspaces, brings places to bring your models to compute. Let me give you a brief video to show you why we do that and what the essential features are. The National Library of Medicine must be the foundation that stimulates the imagination of our investigators worldwide, and also of our policymakers, and also of our patients, because it is these imaginative processes that lead us to ask the questions that are driven by these analyses. I want to turn to some of the logistics, some of the things we're putting in place at NIH to ensure that data-driven discoveries appear and emerge in time. Let's talk about the NIH data infrastructure, and as we envision this right now. Now, you all know the National Library of Medicine is huge. The National Institutes of Health is even huger. $31 billion a year are put into research around the country. We spend $1 billion of those dollars at least already managing data. We need to find out if we're doing it right, doing it successfully, and doing it in a sustainable fashion. So we propose to put in place a robust suite of trans-NIH and institute-specific institutional and public-private data commonses that establish a unified data discovery, data use policies, analytics, and visualization frameworks. We can't simply remake tools over and over again. We need to be sure that we have robust, I heard this morning, calls for greater investment in industry for tool building and in the research environments for question answering. That partnership will always continue in some level of balance, but we want to fundamentally do this from the perspective of NIH to enable scientific advances accelerated and informed by data. The National Library of Medicine is not the only place where data science occurs at NIH, but I must tell you that at NIH, we were assigned through a report to the director that the National Library of Medicine should become the epicenter of data science. Now, I have to tell you, I'm nervous being in California because I've read in the newspapers what epicenter means out here, and I don't want that to happen in Washington. But we will become the hub. We will become the accelerator. We will become, in part, but not completely, the repository of data. We're proposing in the short run to do several things. Devise a PubMed-like discovery resource for data and models that will be modeled on literature discovery, so these don't hang separately by themselves, but actually have a complex web underneath them, connecting data, models, and literature, data, models, and literature. We propose to stand up a resource center with the people, processes, and storage options needed to make data fair, enable knowledge discovery, and effective knowledge management. We understand the need to have expertise at the point of curation. Curation is something librarians have done for years. This is not a new technique for us, but it's a new substrate to do it on. We need to make partnerships to make data discoverable and analytics ready. And in the case of NIH, these are partnerships across the NIH or across the different facilities to which the institutes contribute their funds. Each culture of discovery is slightly different, so we can't have a head nurse that defines all of it. We need to develop the next generation of workforce of cross-trained data-savvy scientists, librarians, clinicians, nurses. I can go down the list. We have to accelerate our education and our training processes, and there's a bunch of people in this audience today who are close in age to me that need training while we're busy, while we have jobs, while we're going on. We need to figure out how to bring scientists into data-framed discovery. And finally, we need to, very significantly, and the National Library of Medicine sees a particular role here in investing in advanced methods research and the development and applications targeted research. Now, we have attention at the NIH campus, I'll be honest with you. We have data science appearing everywhere, which looks like an add-on to a lot of projects, and we need to figure out how we grow and accelerate deep methods while we are recognizing that sometimes they will come as a byproduct of substantive inquiry in specific disciplines. An application-focused research program can generate new methods, but so can investments in methodologies. Finally, and critically, we need to have a sustainable cost model. We are concerned at the NIH that we not disrupt our R01 funding, our training funding, our new inquiry funding for the preservation of data, and yet we recognize there will continually be a trade-off for this. Okay, so here is the NIH, and here is the National Library of Medicine up in the front. That thing that looks like a flying saucer in the front is right where my office is. What is happening right now is investments in an infrastructure that is built on the concept of a commons. The word data commons is used commonly, frequently around. We view the commons as being a compute platform that originates with a compute platform, but has a stack model of APIs, of digital identifiers, of ways to enhance discoverability. It is both a space, place, and concept. We do not anticipate that all data will always be stored at NIH. We recognize the need for partnerships with industry for data, with other federal investments, with community-generated data. But at the NIH, we are standing up a data commons, and over this summer, you will see more funding announcements come out about helping to build that and helping to test that for us. We are at the point where we are pivoting the BD2K process, which stimulated a lot of the data science inquiry and development in the way that we ran data science. And the pivot process is involving two key issues. After 5 years, we found a need to more directly invest in infrastructure immediately. And second, we recognize the need to generate a way to make sure that the products developed under the original BD2K Centers of Excellence and the development of our research programs actually have a place to live after the funding is over. So we're looking at a number of different options about how to integrate and store and harden up software so it's available and reusable. But specifically what's happening right now is, first and foremost, work is being done through the Office of the Director to synthesize and collect learnings from the BD2K centers. We're in the process of standing up something referred to as the Commons pilots. This will be acquiring 3 high-value data sets: the TopMed data set, cardiovascular, the GTEx data set, genome to tissue, and several of the mods, not all the model organism databases, but several of them. Establishing a foundation to, first of all, transfer those data to cloud instances. Secondly, establish a foundation for authentication, authorization, and curation, a sufficiently robust foundation for authorization that allows for moment-to-moment access and deaccessing to the data. Third, we need to document the cost and experience. We know that uploading data to a cloud instance is not necessarily something a first-year graduate student is going to be able to do or should do. Managing version control, moving these large files are challenging, and we need to find strategies for them. And finally, during the Commons pilots, we will be stimulating inquiry. There will be opportunities for you to give us examples, for us to support you in developing new examples of how cloud instance can lead to new inquiry, can accelerate the experience. We have an investment in training, particularly in mid-career training, in data librarian training, and in university-based T32 training. We anticipate releasing a new training opportunity, funding opportunity in the next year to reignite the training activities. And in addition to that, we will be working closely with our sister institutes and centers around NIH to make sure that when data science is added to existing T32s, it's done in a way that both accelerates the base knowledge for that discipline as well as leverages what we're learning about data science strategies. And finally, a challenge that we're faced in a number of places is adequate curation. Terminology. So we heard earlier this morning about the possibility of moving the definition of cancers from an anatomical model to a molecular model. All of these require us to develop the proper indexing, location services, and integration oncologies to make sure that data can be accessible, can be knowable, and can be findable. This is what we're doing to provide a platform for discovery. We recognize we have many other things that also help stimulate imagination. We will continue to manage our literature databases. We will continue to grow PubMed Central with open access to the literature. And as of December of this year, 2017, you will be able to submit data sets in support of articles submitted to PubMed Central as a supplemental file for that article. So we're beginning very quickly to ensure we can link the data and the literature together. But now I want you to move into a new way of thinking about this with me for a few minutes. I want you to move away from thinking about the professional, the scientist, the researcher using this, and to think about how we're going to engage citizens and patients in this conversation. The National Library of Medicine, we also see, in addition to providing a platform for discovery, must provide a pathway for engagement. Now, the public library is one of the most trusted institutions in any community. And we do know at points of crisis, like during the Baltimore riots 2 years ago, it was the public library that was a gathering point for people. We believe this idea of library as a platform for engagement complements clinical practice and self-management, doesn't replace it. And so we're trying to systematically build towards this. As we think about data-powered health, we need to think about it moving from the laboratory into the hands of clinicians and ultimately into the hands of patients. And one of the things that's very important for you to do it right now as you're listening to me is to become mindful. What did that word patient mean as I said it to you? What came into your mind? Was it your mother, who maybe is managing chronic heart disease? Was it yourself when you had an appendectomy or MI a few years ago? Was it some person in a bed with a white gown on? What did you assume that that person could do, could know, could want from data-powered health? And how are we going to reach them directly? I now want you to watch a short video with me to think about a whole different kind of a patient who could benefit from data-powered health.
My name is Erin. I'm 10, and I'm all about skateboarding. I also have cystic fibrosis, which means I cough a lot, wheeze like crazy, and get all kinds of lung infections that put me in the hospital. So my mom's always on my case to take my meds and digestion enzymes whenever I eat. She doesn't like to let me out of her sight. It's like, get off my back already. Okay, so maybe I forget my meds now and then, but it's my life, isn't it? So I've been begging her for a phone ever since I started 6th grade. I mean, all my friends have them. Then, the other day, I had an idea. I was taking all 20 million of the meds I need to stay healthy and thought if there was one thing they'd go for, it would be something that helps me with CF. So I do some Googling and find this site called My MediHealth. All you gotta do is use this program on your phone, and it reminds you of all your medications that you've gotta take and when. Sure enough, Mom was psyched. So I get the phone, and my mom helps me put my med schedule together. I bring my phone with me everywhere, just like my skateboard. But it does take me a little while to get used to. Like Friday night, I'm over at my buddy Jason's house playing on his console when my mom calls. She just got a text from my MediHealth saying I haven't taken my antibiotics. I look at my phone and see I missed the alert. I take the pill and press a button to show that I've taken it, and she gets another text saying I'm all good. So at first, my mom's still on my case. But the cool thing is, my MediHealth shows her and the doctors that I'm taking most of my doses now.
It's important to remember that the patient may be a kid on a skateboard somewhere, and the information that we need to understand a pathology, to characterize the phenotype, or to know that our interventions are working, may be in the hands of that kid. So we need to think about, as we look at training for the future, we need to think about not only how will we train professionals, but how will we engage lay people, patients, moms, children in data-driven health. Data-powered health requires us to help people rethink not only what healthcare is, how we learn about what healthcare is, but how they participate in helping us know. But at the point of knowing, we need to make sure they return, they receive, they have information that returns to them. Now, our innovative training not only has to address how do we engage people in helping us look at the whole precision health pipeline, look at the whole data-driven health pipeline, but how do we engage health professionals in that? Our health professionals are busy. They've got a lot going on already, and we want to increase the uncertainty of their decision-making by introducing them to data-powered health. We have to find ways to change our medical school curriculums, our curriculums in schools of nursing, and we have to reach into K-12 to bring numeracy into society in a way like it's never been before. Our challenges are many, but the National Library of Medicine has some very good resources for this. Going back to what I said about libraries, we have our national network of libraries of medicine, 6,500 points of presence around the United States. Some of these libraries are in academic medical centers like here. Some of them are in small communities. And through our national network of libraries of medicine, we have the capability to send out into the community the kind of new information in the moment, transformative tools to help people participate in data-powered health. In addition to that, these libraries also serve a professional role. Some of you may have already encountered how our librarians are helping people upload information into clinical trials or make an appropriate data management plan. That's important, but I want you to remember also they're going to help us reach citizens. In addition, the National Library of Medicine is releasing a new initiative, Personal Health Libraries. Personal Health Libraries is an RL1 mechanism that's designed to figure out how do we use informatics to get data into the hands of patients and back to us. How do we engage patients in data-powered health, and how do we use technology to do this? Now, I want to close my remarks by asking you to think with me for a few minutes about the new policy frameworks that have to be put in place to make sure data-powered health actually becomes a reality. It cannot be done by science alone. It cannot be done by clinicians alone. Data-powered health is going to require policy change. And first and foremost, we have to remember that the electronic health record is not enough for us to have policy support for data-powered health. We have to think about protections of data captured in the moment, storage of that data, what constitutes data that must be HIPAA protected and not HIPAA protected. As you begin to think how to engage, how to link the electronic health record into the kind of discovery pathways that you're already using, which I understand is still relatively new, I'm now asking you to take a step further and take accelerometer data from a cell phone or information from a person self-monitoring their anxiety levels and think about how that comes into our research pathways. We need safe and trustable ways to manage clinically generated and patient-generated data. We cannot upload into the electronic health record every possible ping from a cell phone that says you walked your 1,800 steps today. We have to figure out what is the repository, what is the distributed information repository that is necessary for data-powered health. Third, and this is critical for the clinicians in the room, we need practice permissive policies that support the use of that patient-generated data and enable inter-visit activities and care actions. Often right now, we think about our policies needing to manage the care in the moment through data that is collected in the electronic health record. There's lots of protections around it. When we move into an information-based, technology-supported health in the moment of everyday living, we have a broader platform on which clinical decisions are made, and we have to help our clinicians have the legal protections to be able to use that. We need an expansion of concepts of confidentiality and privacy to better fit these new models of data-driven discovery and data-informed care. We need to be sure that a kid who's tracking at things that may be considered unacceptable in the family, whether it's desires to smoke marijuana or sexual activity, should not have that observed by a parent through a phone. How do we ensure privacy of an older person trying to decide the balance between intimacy with a partner who is now showing signs of dementia and respect for that individual? We need new ways of thinking about confidentiality and privacy. We need to separate permission from acquisition and use. Those of you who look over there at that electronic health record with great hope of characterizing the phenotype quickly need to remember that at some point someone's got to ask the patient, can we use your data this way? And then we have to find ways to preserve those permissions throughout the entire use of that data and the reuse of that data. It cannot happen in the moment that we're trying to acquire the data from the individual. We need to have society better understand where the society fits in data-powered health and find ways to identify universal consent and longer-standing permissions and permission and policy managers from the perspective of the patient. And finally, it's critical for us to engage in the public-private public dialogue that explores the interplay between open science, patient privacy, and data-powered health. Should patients have access to our BAM files? What does it mean when we open our data to everyone? How do we move into a society that's been previously driven by intellectual property concerns and rights of data to one that is focused on the sharing of data? We have lots of work to do. I hope you'll join with me in doing this work. You can reach me in a number of ways. I am available through email, of course, and Twitter, but I also have a blog once a week at National Library of Medicine Musings, and that will be a place where we can continue the dialogue of how we're going to accomplish data-powered health for all. Thank you for what you do. Thank you for what you've done already for my family, and good luck in your work.